Hello and welcome to this video abstract for the Family Process paper, The Effectiveness of FFT in Reducing Adolescent Mental Health Risk and Family Adjustment Difficulties in an Irish Context. The paper was written by myself, Dan Hartnett, a PhD graduate of University College Dublin, Ireland, Professor Alan Carr, Professor of Clinical Psychology at University College Dublin, and Professor Tom Sexton, Director of the Centre for Adolescent and Family Studies and Professor of Counselling Psychology at the School of Education, Indiana University. The paper describes a randomized controlled trial of the effectiveness of functional family therapy conducted between 2012 and 2014 at a community-based organisation, Archways Families First, where a team of therapists trained by Professor Sexton have been delivering FFT in a socially disadvantaged suburb of Dublin since 2007. FFT is an evidence-based treatment for adolescents with behavioural problems, which has been shown through a number of outcome and process studies to be helpful in improving youth and family functioning and reducing behavioural problems and criminality. In Ireland, up to about 20% of adolescents have significant behavioural problems, but few evidence-based family intervention programmes have been established to address these difficulties. Archways Families First was the first site in Ireland to implement FFT. In our trial, we randomly assigned 42 families to receive FFT and 55 to a waitlist control and collected data from both parents and adolescents. We used the Strengths and Difficulties Questionnaire, the SDQ, to assess adolescent behavioural problems and risk of mental health difficulties, and the Systemic Clinical Outcomes and Routine Evaluation, the SCORE, to assess family functioning. Families were admitted to the trial only if they scored above the clinical cutoff point of 17 on the parent-completed version of the SDQ. Therefore, all adolescents in the trial were displaying severe behavioural problems pre-intervention. A team of therapists delivered therapy to individual families to a moderate degree of fidelity in approximately 20 sessions over 4 to 5 months. Our results showed that rates of clinical recovery were significantly higher in the FFT group than the control group, and compared to the comparison group, parents in the FFT group reported significantly greater improvement in adolescent problems on the SDQ, and both parents and adolescents reported improvements in family functioning on the SCORE. In addition, 93% of youth and families in the treatment condition completed FFT. These improvements shown immediately after treatment were sustained at 3 months follow-up. Now, we believe that our results have 3 key implications. Firstly, most previous studies of FFT have focused on reducing recidivism. And while important, recidivism may not be specific enough to guide the use of FFT in practice settings in which justice involvement is not the key indicator. The current study is the first FFT randomized trial to use a comprehensive measure of youth mental health risk and a well-validated measure of family adjustment as outcome indicators. The finding that FFT has a significant positive effect on measures of adolescent mental health risk and family adjustment in an already disturbed clinical population suggests that FFT is appropriate for use in mental health settings. Secondly, the study demonstrates the cross-cultural reach of FFT as a treatment model. FFT was implemented in an Irish mental health context in a community setting delivered by Irish FFT therapists to Irish youth and families. The current study is one of the first published randomized trials of FFT to be conducted outside the US. We could identify only 2 other published international trials of FFT, both of which were conducted by Hassan and colleagues in Sweden. Finally, the study adds to our understanding of the FFT implementation process, and in particular the importance of training and supervision in producing good outcomes. The therapists in the study were community-based practitioners, and as such they did not receive the support typically provided to therapists when RCTs are conducted in laboratory settings. Despite this, the outcomes in the current trial were on a par with those of previous studies conducted in less real-world settings. This suggests that the FFT implementation model can be used in community settings to create the same level of support as is found in laboratory studies. Thanks for your interest in our work. We hope you enjoy the paper.